Hey, well, hello everyone. Welcome to Wellness Wednesday. Thank you all for joining us this afternoon. Today we're going to be talking about freezing of gait, and today we have Dr. Kathleen Lawrence from Power Back Rehabilitation to you, who's going to be talking to you all today. During the session, we ask that you keep your mics on mute, and if you have any questions, we will have a Q&A session at the end. But if you have any questions that come up throughout the presentation, go ahead and drop it in our chat box, and we'll be happy to go over that during the Q&A session. So I'm going to go ahead and turn it over to Dr. Lawrence here, and we'll get started.
Thank you. I'm going to share my screen, everyone. So just give me a minute to get it set up and in presentation mode, hopefully. There we go. So hopefully y'all can see it okay. If you can't, someone let me know. But today's presentation will be on freezing of gait. And sorry. Wanted to start with just telling you a little bit about me. So I am a physical therapist.
That's not mine.
I'm a physical therapist. I graduated in 1999 and I received my doctorate degree in 2005. I graduated from the University of Wisconsin-Madison. So I'm a Wisconsin Badger. I started specializing in Parkinson's disease 2 years ago, but definitely have treated a lot of neurologic conditions my whole career. I'm LSBT Big certified. I have my Power Move certification, and I'm currently working with Power Back Rehab and Rehab to You. We do in-home outpatient therapy, and we also have a gym at Memory and Movement in Charlotte, and we partner with them to provide therapy to all of their patients there. And my cat might say hi to everybody today. So the objectives today, my goals for you are that you're going to learn about freezing of gait and the different variations of freezing of gait, discuss and learn why freezing of gait happens, and then learn how to overcome it with some simple yet very effective compensatory strategies. So what is freezing of gait? So you'll see FOG, FOG is the abbreviation I'll use through the presentation. Freezing of gait is described as these brief arrests of stepping when initiating gait, turning, or walking straight ahead. So it's literally just freezing while you're trying to move. It's very unpredictable in its character. It's hard to predict when it's going to happen, when it's not going to happen. It's the leading cause of falls and injuries with people who have Parkinson's disease. It results in loss of independence, sometimes wheelchair use, worsens anxiety, and can cause social isolation. The impacts of freezing of gait, obviously it impairs balance. We'll talk about that more. It increases your falls and your fall risk. It overall reduces quality of life, and it creates a self-limiting behavior where folks stop walking or stop going into the community, being fearful of having a freezing of gait episode or falling. The pathogenesis of freezing of gait is still really poorly understood. There's a lot of hypotheses, but the main hypotheses we think is that it's likely an abnormal coupling between posture and gait. So it's a postural stability issue. So in my PT world, we understand it as a weight shifting issue. And we'll get more into that, of course. So freezing of gait occurs in over 50% of Parkinson's disease patients. And as they advance with their Parkinson's, it increases up to even 80% when you kind of get to that advanced Parkinson's disease phase. So freezing of gait can differ between patients, so it doesn't always present the same way. There are some characteristics that are similar, but everybody does kind of present a little differently. Sometimes it's a shuffling with the gait. Sometimes it's the trembling of the legs in place. So the legs are just going and going and going, but there's no forward movement. It also can be a total akinesia, which is no movement at all. So you can just literally be stuck in place and no idea how to move forward. My patients, most of them describe it as their feet are stuck in mud. So, you know, when we're working together, they'll say, I just feel like my feet are stuck in mud. I can't lift them up. It impacts initiation of walking, so taking that first step. It's especially impactful for transitional movements. When you're going from walking and you're going to sit down, making that kind of turn into the chair, a freezing episode might originate, and it might even originate feet before you even get to the chair, because there's already a cognitive component causing anxiety and creating that freezing of gait. Turning definitely can cause freezing of gait. We'll talk a little bit about why that happens. And then we see this a lot walking when there's different constraints. So this is when you're going through a doorway. There's lots of freezing, either because of the doorway or because there's threshold change that triggers a lot of freezing. Narrow spaces, going to a restaurant where maybe you have to weave through the chairs, that can cause the freezing of gait. And any change in the floor. So if you're in your home and you're going from carpet to hardwood to carpet, there's going to be a lot of freezing. And of course, rugs can be triggers for freezing. Going from indoors to outdoors, just that change from indoor flooring to concrete can cause freezing. So there's a lot of triggers, and everybody is very different in what their personal triggers are. So one study was based on patient self-reports, and 62% of people who do have freezing of gait have this off phase freezing of gait. So that's when you're taking carbidopa, levodopa, but it has already kind of worn off and you're going, and now you're in an off phase, but you can't take your next dose for, say, like another hour. That's usually when people get most of the freezing of gait. Some, about 36%, have this on-off freezing of gait, which is when you're in the on phase and you're going to the off phase. And only 2% have on freezing of gait. So we'll talk a little bit more about why that is. We'll talk about the medications and the effects on freezing of gait as well. It's a very interesting, the research on medication. So I have a couple of videos. So just give me a minute to change to the video. So let me end this and pull up the other one. All right. So I think you all can see this well, I hope. I'm going to just show a little bit at the beginning of this video. This is a great video. I just took it off of YouTube. And this is going to show us some freezing of gait. I'm actually going to turn the volume off because I just want to show you this particular person and what the freezing of gait looks like for him. So you can see they're categorizing him as being in this off phase. So his medication is he's not on his medication currently. And you can see the turning and how the freezing becomes pretty substantial during turns. And you can see that he's just really struggling to move. And we'll just watch this a little bit more here. This shows kind of a change of surface, so you can see just the color differences in the floor too. When you get to a doorway, what can happen with that as well. There's a good example there. Another video I want to show, but I want to see, oh, this is just turning in a full circle. This one has intervention on it, so I want to pause it before I get to the intervention component of it. I think that's it. So I'm going to pause here. And then just one more video that shows this person seems to be a little bit higher level. And you'll be able to see their freezing. And so this one is like the trembling of the legs. So with his shorts on, you can see it a lot easier. Those legs are just trembling as he's trying to turn around. But you can see he walks pretty well. So those are kind of the two different videos of that. I'm gonna go back here because we're gonna pop back there later. But just wanted you to see a little bit, see if you can recognize yourself or maybe your family member in those videos. So how do we assess freezing of gait? It's really important to have a physical therapy evaluation. I put on there, can be occupational therapy too. But usually when it comes to gait and gait training, you are dealing with a physical therapist, and we have kind of two ways to assess it. I mean, obviously we're assessing visually what's going on, but there's a freezing of gait questionnaire that we can go through with folks where it's more like a self-report about the freezing of gait. And then there's a freezing of gait assessment. So we're assessing initiation of gait, we're assessing turning, going through doorways, floor changes. We're kind of assessing all the areas that we kind of know will trigger freezing of gait, and then kind of giving them a grade. And the grades are based on the frequency and also the duration. So the duration of freezing of gait is important too, because some can have a super quick response to freezing of gait and kind of break out of it quick. And some can stay in their freezing of gait for quite a while. I think someone's raising their hand, but I don't know how to address raising of hands. So I don't know if Kiana can help us, if she can hear us. But once I can address the raising of the hand, I will.
Mr. Hammond, do you have a question? Oh, wait, let's unmute you.
But there's an option for those of us on Zoom to record this presentation. And I know some of these, you need permission, your permission. Is that granted, or is it, is it easy for you to provide that?
Yes, so we will be recording this session. We actually are right now. And so it'll be available tomorrow, as early as tomorrow, on our YouTube page.
Okay, that's fine. So it's unnecessary for us to record it. We'll get a copy from you.
Yes, and I will make sure I send it to you directly. That way you have the link, okay?
Good, thank you for, sorry to interrupt. Thank you.
Perfectly fine.
All right, thank you. Okay, so on to kind of freezing of gait and our perspective from PTOT, what our perspective is on, sorry, I didn't put this into, I didn't put it into presentation mode, sorry. So this is kind of our perspective on freezing of gait. There was a study that supports some of our theories on how we treat freezing of gait. And this first one was impaired weight shift amplitude in people with Parkinson's disease with freezing of gait. So they kind of found this hypokinetic weight shifting proved a marked postural control deficit in freezers. So what that means is the weight shift amplitude. So the amount of shift from one side of your body to another to offload was reduced in folks who have freezing of gait. And that the freezing ratios were responsive to medication in freezers, and that suggests that there is some levodopa responsiveness to freezing a gait. And I have a whole section on medication, so we'll go over that more. And so this is likely why there's about 3 different subdivisions of Parkinson's disease. And if you're kind of in this postural instability, gait abnormality, Parkinson's disease, you're going to have a higher risk and higher frequency of freezing a gait than we see in more of the tremor dominant or dystonia dominant subcategories of Parkinson's. And it's likely because of this weight shifting issue. We observe in our therapy sessions that weight shifting is what corrects freezing of gait when it's happening, and that practicing and training on weight shifting can reduce the onset of freezing of gait in therapy sessions. So when freezing of gait occurs in turning, this is likely because when you're turning and the upper body is freely moving and the feet aren't coming with, you actually lose the ability to weight shift. So there's a lot of strategies to work around that. Another study that supports the work that we're doing is recoupling the attentional and motor control of preparatory postural adjustments to overcome freezing of gait in Parkinson's. Everybody has to use fancy words, so it sounds important, right? So this studied whether people with Parkinson's disease can be trained for a preparatory weight shift to avoid freezing of gait, which is one of the compensatory strategies we'll talk about. So at baseline, they also found that the weight shift amplitudes were smaller in people who were having freezing of gait. They found that both verbal and analogy training resulted in significant increases in weight shift amplitude and a corresponding reduction in unsuccessful attempts to initiate stepping. So, it's saying with verbal training and the analogy training, which is preparatory training, folks were able to overcome that freezing with an initial step, and they were successful. This one, the wording is a little confusing at times. So their conclusion is that impaired weight shifting characteristics are modifiable through conscious strategies. So this study supports our understanding of the use of what we call rescue techniques. So when people are actually freezing and frozen, we have what we call rescue techniques. And it's called, we call it the 4 S's. It's been called a couple different things, but we'll go through that later in the presentation as well when we go over interventions. So what are some interventions? What helps? That's the biggest take home, right? Everyone wants to know, how do I fix this? How do I help this? So does medication help? Does physical or occupational therapy help? Are there external interventions that help with freezing of gait? So we'll start with medications. There's a little bit of confusion with the medications, and unfortunately is definitely not black and white. So this is a study that discusses all the different on-off freezing of gaits, and that's the diphasic worsening of freezing of gait in Parkinson's disease. And they looked at the relationship of freezing of gait and levodopa responses, and they recognize that it's just very complex. Some patients respond and some have no response, unfortunately. So this case study was of 2 patients who actually had increased freezing of gait when they were off and they were trying to get to on. So they were off, they took their levodopa, and now they're trying to get to this on period. So during that time period, their freezing of gait actually worsened during that transition. But when they got to their full on state, which was 45 to 60 minutes after the dosage, their freezing of gait then improved. So this was self-reporting. So they were feeling that the levodopa was actually worsening their freezing of gait for a short time period. Patient 2 in this case study did a levodopa challenge, which they were given a boost of levodopa and then tested, and they basically had the same feelings, that initially the freezing of gait was worse and then subsided once they were fully in their on period. So, and in this case, neither of these patients had freezing of gait when they were going into the off phases. So that was interesting as well. So prior to the levodopa era, there wasn't a lot of documentation on freezing of gait. So this does suggest that levodopa may actually play a role in the pathophysiology of freezing of gait, but then it is also the answer for freezing of gait. So I think that is interesting. So a couple more medication studies. Levodopa changed the severity of freezing in Parkinson's disease. This study suggested that levodopa does reduce freezing of gait after 60 minutes of a dose, and it was abolishing festination and freezing of gait in 20% of the subjects. So festination, if you're not familiar, is the super quick steps that sometimes occur with Parkinson's, where you're not able to start or stop your forward movement. And sometimes festination and freezing and gait are very intertwined. Another study was the study about, did freezing of gait exist before levodopa? So this was a historical review of all this research that was done prior to levodopa coming to the market. And freezing of gait was rarely mentioned in the historic literature. So it's really interesting that freezing of gait wasn't really fully noticed until after chronic use of levodopa. So those are just some interesting medication studies that I came upon. There's a lot of studies out there. So the take-home message is, although levodopa might be responsible for freezing of gait, it is also the answer to freezing of gait. All right, physical therapy interventions. So you really, if you have freezing of gait, you have to work with a trained or specialized PT or OT. It's really important. Freezing of gait is a very unique symptom of Parkinson's. It's a very frustrating symptom of Parkinson's, and it really needs to be handled by professionals who know what to do for freezing of gait and how to help you through it. In our world, LSVT big, which I'm sure everyone on here has heard of, it's the most popular Parkinson's disease physical therapy treatment out there. But there's also Power Moves, which is probably secondary in popularity, which is another intervention for Parkinson's disease. And these are therapists who provide these services are certified and have certification, special training to provide these treatment sessions to those who have Parkinson's. So both programs, although slightly different, they focus on big amplitude movements and weight shifting. So we know weight shifting is the issue with freezing. We know weight shifting is the answer with freezing. So both of these programs incorporate that into their sessions. Both also work on normalizing your gait pattern with larger amplitude stride. That was supposed to be stride, sorry. My spell check left me down. Larger amplitude strides and a faster gait speed. So if you're taking really large steps and you're not shuffling and you're walking at a normalized gait speed, your likelihood of getting into a freezing moment is reduced. Although there has been no studies at all specific to freezing of gait and either of these programs. Hopefully it's going on right now, but there's nothing out there that I could find that was very specific regarding freezing of gait and these programs. I can tell you for sure in the clinic that we see a difference. We do see reduced freezing of gait. Of course, we're adding in a lot of compensatory strategies and all the other things we know to do for freezing of gait. But these interventions do work, and they do reduce freezing of gait and give people the tools that they need to succeed. Physical therapists, we're also going to teach and train on any external interventions, which we'll talk about in a minute. And then we can teach the compensatory strategies like the 4S's rescue plan, which is next. So the 4S's, we call it the 4S's. Some call it the 5S's. There's a bunch of other names out there. Everybody has kind of taken kind of one set of instructions and have kind of made them their own. I kind of stuck with 4 because it's less steps for someone to remember. But the most important thing is, so this is this is like a rescue. So this is, you're going to do this when you are freezing. So you or your loved one are frozen, you're trembling or you're without movement. The biggest thing that you do, number one, is you stop moving, you stop fighting it. So imagine, the computer when you get the, you get the spinning and you're waiting. And finally it's like, you just got to shut the computer down. That's the same thing with when you get in this freezing. It's just a broken circuit from your head to your feet. The message is going and going and going. It's not the right message. It's wrong. It's not going to get you anywhere. Younger folks earlier in the disease sometimes can overcome it. Some people can't overcome it at all. The best thing to do is to just literally stop. You stop in place and you stop moving. Okay. The next thing you do is you stand tall. So a lot of times, we have this forward flex posture with Parkinson's, and you just stand up really tall. And I always say, take a deep breath, because when folks are in a freezing state, the anxiety starts getting really high. It's just natural, you're stuck and you're scared and you don't want to fall. So anxiety starts going up. So you just take a deep breath and relax. And then you want to weight shift side to side. Now, if you're frozen in a mid stance, you could weight shift forwards, backwards. So wherever your feet are. So you're either shifting forwards and backwards, or you're shifting side to side. So you're trying to get that rhythm back. You're trying to get that weight shift, and you're trying to reestablish the connection with your brain about what it's supposed to do. And then you tell yourself to take a big step forwards or sideways, depending whatever direction you're trying to go. And you tell yourself to take that big step. And it works like a charm. I mean, people come out of their freezing just miraculously with the 4S's. Now, sometimes someone has to take a step backwards in order to take a step forwards. So sometimes it's just figuring out what works for each person. Like I said, Parkinson's is so unique. Everybody is different. Everyone's freezing is different. Everybody's triggers are different. So, it's really important to kind of figure out exactly what works and then stick to it. So once you get the plan, you have the plan, we teach the plan, you learn the plan. If a patient can't learn the plan, the caregiver learns the plan, and now you're able to get out of freezing in the first place. Now, preventing freezing in the first place would be the optimal goal, but there will always be a time where freezing will occur. So some external interventions, I'll show some videos in a little while as well. Visual cues work amazing. Stepping over lines on the floor. A lot of times I do a lot of in-home, so they don't want tape on their floor. So I'll use colored agility circles where they're either stepping on the circle, or they are stepping over, whatever works for them. Sometimes just stepping to the dot works and they get their really large step, or stepping over the dot will help with the freezing as well. Folks who don't mind, will tape up their whole house so that there's always something for them to see visually, or we just target that troublesome area. Bathrooms are huge area where freezing of gait occurs. So a lot of times putting the tape just in the bathroom is very beneficial for folks to avoid freezing in the first place. Some people like to use a metronome. So that is just the ticking, tick, tick, tick. And it, for some reason, it makes a brain connection, and people will rhythmically walk. To me, trigger avoidance is number one. I should have put that number one. Trigger avoidance to me is number one. Don't have the freezing happen in the first place, and do whatever you can to change the environment if that trigger is occurring. Now, sometimes you can't, sometimes you can. Throw rugs, anything that's changing the pattern on the floor. Just at some point, when you cannot overcome, needs to be removed. Make your life easy. Rugs are pretty, but it's going to cause you to freeze every time you walk into that room. It might be worthwhile to not have that trigger. Some trigger avoidances are just not looking at the floor, period. So with doorways, threshold changes, that's the compensatory strategy we teach a lot, is don't look at the floor. So the cue is just look straight ahead and just walk through it. And if folks don't see the floor change, they don't freeze. So there's definitely a visual component to the freezing as well with the floor changes. And again, a lot of this stuff is just unknown, why it occurs. We just know it does. Whatever compensatory strategies we can provide through PT. Sometimes we recommend a U-step walker. I have a little picture of it there. The U-step walker can have a laser on it. That gives a visual cue to somebody when they're walking. The U-step walker is nice because you have to squeeze it to move it. So if you start festinating, you can release the brakes and it will help you stop. You can use a cane with the laser as well. So there's just a little gadget that you can attach to a cane. If the laser is what works best, both of these devices can also come with a metronome. You can just have a visualization. So, you can just visualize before you do something that is going to be hard. Like maybe you're going to go into a dining area, you're going out to eat with your spouse, and before you even walk in the door, you're visualizing what you're going to do. You're going to visualize that you're looking up, you're not looking at the floor. You're going to visualize taking your big steps all through to where you need to go. You can visualize if you're getting to a threshold and visualize that you're stepping over something to get into that threshold. There's a ton of compensatory strategies that you can do. Some people sing. I've definitely had patients have little songs that they'll sing to themselves that work for them. Some people just count when they know they're in an area that they can't handle, like a bathroom. And that's just their strategy that they use. And it works well for them. Like I said, everybody is really different. So the Parkinson's Foundation put out an article, which you all have probably seen, about the top interventions for freezing of gait. And this is from the Journal of Neurology, and this is Managing Freezing of Gait in Parkinson's Disease, a systematic review. And the results were that the best treatments for freezing of gait is obstacle training, gait training on a treadmill, and exercises, and that they really do show an immediate real life benefit compared to usual care. So this was not a research, the exercise was not the power moves or LSVT big, it was just more generalized exercise. So this just shows, you really have to, if you're gonna do obstacle training or training on a treadmill, you want to work with a specialized PT for safety. A lot of the clinics will have a light gait treadmill, so you're harnessed into the treadmill, so there's no risk of falling. But obstacle training had the greatest and the most immediate positive effects based on this article that was written. What they also found was it was only people with mild to moderate Parkinson's disease that experienced the beneficial effects of freezing behavioral treatments. That's just what the study says. Doesn't mean it's true. That's just what they took out of their research. So these are kind of all of the things they looked at. I'll just point out the ones that are probably realistic and what you might actually get to do. So obstacle training, gait training on a treadmill, general exercises, focusing on non-freezing specific exercises, dual task training, which is doing two things at the same time. It's usually a cognitive component with your physical component. External cueing, as I mentioned, observational training. Virtual reality is becoming kind of a new thing in physical therapy, so I'm sure there's going to be some research coming out on that very soon. These are kind of some of the most popular ones. I know it's getting to the end. So one more video on the guy we saw earlier. And let's see what happens when we give him some visual cueing. So if you remember, so you see the floor change. And he has no problem at all with the floor change. So if you remember this one, you can't hear it, but it's a metronome going off. I turned the volume off, but it's going tick, tick. So every step he's taking, there's a tick, 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 tick. And it's helping him with that floor change. Now this is when he's in his on phase. So the levodopa is in full effect, doing well. Look at that turn. Definitely a little loss of balance there. But he's doing really well. This is the door there, and turning in the full circle. So those just kind of show a little bit of how beneficial the compensatory strategies can be. So hopefully, I think I went a little bit over. I was trying to be a little speedy at the end, but I'm ready for questions. I think somebody did have their hand raised, Kiana, somewhere along the way that I missed. It was right at the end though, so I knew we were wrapping up.
Yes, Miss Marcia, you had your hand raised earlier. Okay, and she actually just put it in the chat.
Yes, I did. My question was, can you share a program for the gait training on the treadmill? I've Googled it and I cannot find it anywhere except the benefits of it on the treadmill. I've done power. I've done it, for years, so I'm very good at power, and had certified.
Good. Yeah. I wonder if the place that you had your training at would have had a treadmill there. So what we do in our clinic, we have the light gait treadmill. So we harness everybody up just for safety purposes. And so there's no falling. And what we do is we get folks on the treadmill and we push their gait. So it's that continuous walking. So a lot of times it's hard, especially in a clinic, to get somebody to walk for a long distance so that you can kind of accurately address some of the freezing issues. So we walk them for a long time. A lot of times there's cognitive components. So while they're walking, we'll start talking to them, and then we'll see them start getting that freezing of gait, and then we work through it. And we practice that to reduce the freezing of gait. We might have them when they're walking, we might have someone come up on the side and say, "Hey, Bob," so that they turn their head, that they get a distraction, trying to get them to be able to overcome and not get a freezing of gait episode in the first place, because that's really what we're looking for, is trigger avoidance. And then what we're really doing is normalizing the gait pattern. So we want those nice long steps. We want the heel strike. We don't want shuffling of gait. And we're able to do that over really long distances when you do it on the treadmill. So that's kind of what the program is. So I don't know,
I'm doing power now. I just had total knee replacement. So what I'm trying to do is get my gait back. So I don't really have the freezing. It's just, especially when I'm fatigued, I'm doing the shuffling. And where we're going now, they do not have a treadmill.
Okay.
Yeah. And then the other place is an hour away. So it's not something, and we have a gym a mile away from us in our neighborhood. So that's where, and like I said, I've Googled it, just like you can train for training a marathon, you do this and,
Yeah, I never really have gone online and just looked up for treadmill programs. It's just everything I've gotten from my training is what I've used. So I don't have anything super specific for you regarding that.
Okay. Yeah, I've looked and the benefits are great. It's just not, there's not telling what, specific program, and maybe because there's a degree of difference in everybody.
Yeah.
All right. Sure. Thank you.
Yeah.
Oh, right.
So someone asked, does this happen when driving or getting in and out of a car? So hopefully not with driving. Now it can freezing can happen when you're trying to stand up. So obviously getting in and out of a car, you might experience that freezing. And usually it's the attempting to rise part that causes the freezing, because you're trying to stand up and you just can't, your body is just kind of stuck and you're kind of freezing. It looks a little different, but it definitely happens getting in and out of a car, standing up from chairs. I've seen it happen with people when they're doing their ADLs. So they'll start doing something and then they'll just really become, without movement, and they'll just kind of freeze in place until you provide some sort of cue for them to keep going. So it can happen in a lot of different activities as well. The intervention, I'll say the intervention is really the same. You're kind of stop, refocus. You're either giving yourself a cue or you're getting an external cue from somebody else to use a big movement of some sort. So when you're trying to stand, trying to get out of the car, you're doing your big reach technique. If you're doing your ADLs, you're trying to do a big, fast, powerful movement, depending on where you are stuck in your ADL.
Okay. We don't have any other questions in the chat box, but I do want to let everyone know that since we are in the Q&A session, you don't have to type it in the chat box anymore. You can go ahead and come off of mute.
Can I ask a question?
Go ahead.
Okay, I'd like you to discuss anxiety, the relationship between freezing and anxiety. Does that anxiety causes freezing? Does freezing cause anxiety? My wife, when she's freezing, she seems to be, the level of anxiety goes up. Now, if you would talk about the relationship between the two, how they're related, and if one can be without the other.
Yeah, so I'll just speak from personal experience. I don't necessarily have any studies to quote you right now. So this is just my personal experience over the 2 years dealing with freezing of gait. So anxiety can increase. I'll start with having anxiety first. So anxiety can increase the likelihood that somebody is going to have a freezing of gait episode. It's that anticipation of having to do something and the anxiety starts going up, or there's already thinking in their head, I don't want to freeze. I'm going to the chair. They're probably 2 or 3 feet away from the chair and their anxiety is already through the roof because they're trying to figure out how they're going to get in the chair and not freeze, or, get in the chair safely. And the anxiety goes really high. And then I think it even increases the chance that the freezing is going to happen.
Yeah, if we go out to dinner, the anxiety of getting dressed and putting makeup on and making sure that you get your hair combed.
Yeah.
That's all anxiety that just makes her evening just, unbearable for her.
Mm-hmm.
So
Yeah.
her quality of life is really limited now.
Yeah. Freezing gait really has a huge impact. It self-limits people. It keeps people from wanting to go out. They don't want to deal with it. They don't want to deal with the anxiety or how it makes them feel. Even though if they went out, they would have a great time. Likely, if they could overcome some of their issues, the anxiety is such a barrier with folks when it comes to these issues, for sure. And then when someone freezes, the anxiety goes even higher because they're in this state of, like a computer, and their body is telling them something that's not right, and it's just going over and over, and they're stuck there. And then the fear of falling really exacerbates. So the anxiety goes even more through the roof, which is why when we use the 4S method, to me, it's so important just to get that person to take a deep breath so they can kind of let it go. Let some of that anxiety disappear with their big breath. And I would feel like if you had really good training on compensatory strategies, really good ways to overcome freezing of gait, that maybe the pre-anxiety would go down a little bit because she would know that she had tools in her pocket to use, and that she could overcome it and kind of be in charge of her body. So that maybe the anxiety would go down a little bit. But Parkinson's in general and anxiety, they go hand in hand, I think.
Yeah, I would agree with that from what I've seen.
Yeah, I think all my Parkinson's patients have some form of anxiety. So we asked Dr. Iyer at Memory Movement one day, we were like, so if someone has anxiety, are they more likely to develop Parkinson's? Like, is it something with the anxiety that triggers a Parkinson's? He did not have an answer for us, but I think it's definitely an interesting question.
She takes a medication for anxiety from a local psychologist that has been recommended to her from her doctor. It helps a little, but I don't think it helps a whole lot.
Yeah.
Thank you.
Yeah, you're welcome. Thanks for the question.
Yes, Mr. Hammond?
Oh, I think you're muted, Mr. Hammond.
Here, let me try and unmute you here.
Sorry about that.
Okay.
This may be a little off center, but there's some relationship between the carbidopa, levodopa, and on periods and off periods. Sometimes I'll go to bed at night and I will not take the ER, and I wake up 8 hours later, and I feel almost normal. I get up out of bed and I can walk normally. My gait is normal, no freezing. And then, I'm reminded that I have to take my medications, let's say at 8 o'clock, and I take them at 8 o'clock, and by 8:30, I'm back into the negative mode. So do you have any comments on that? I mean, should I'd like to stay compliant with the medication regimen, but sometimes it just baffles me.
That is very baffling and definitely nothing that I have ever heard before. The only thing I ever hear from people is that they wake up in the morning and they can't move. They feel terrible in the morning because all the carbidopa has left their body, and they just have to wait to get their, a lot of people take their rescue dose in the morning, and they're just dying to get the medication so that they could start moving freely again. So you're like the exact opposite of everything that I hear from my Parkinson's patients. So I would definitely go back to your doctor and give him that feedback that you just stated, because I think that would be really important for him to hear. Because if you think about it, when you're taking the carbidopa, levodopa, now medication is not my, lane to be in. But we know that the dopamine pushes to the brain, can cause a lot of different things. So, in your case, there might be an adjustment that has to be made. I would definitely go back to the doctor though and tell him exactly what you just told me.
Thank you.
Yeah.
All right, do we have any other questions? Let me double check the chat box here. And remember, you can come off mute for your questions if you have any. Okay. Hi, Nicole. Nicole Levine says, Kathy is fabulous.
Oh, I know you, Nicole. Yes, we need to hook back up for sure. My email's on the presentation. If you can see it, you have to shoot me an email. I think I've lost your contact solutions or contact information along the way of my transition. Well, if there's no other questions, I want to thank you all for listening to my presentation, and I hope that it was helpful and that you got at least one new bit of information that you can use or share, or maybe it'll lead you to a physical therapist in your area that's trained to work with Parkinson's and get some help with your freezing of gait. Thanks, Jenny. It's nice to see you.
So thank you everyone for joining us today. Thank you, Kathy, for this amazing presentation. Just a reminder to everyone, this will be uploaded on our YouTube page as early as tomorrow, so you'll be able to access all the information again. If you have any questions for me, feel free to reach out to us at PAC. And if you have any questions for Kathy, her contact information is there. So if you have a pen and paper handy, go ahead and jot that down. Okay. Well, I'm going to go ahead and stop recording here.